Good, so this is the start of YouTube video number 4. So the third myth is that the most common metrics used today to measure quality will help decrease costs and save lives. Unfortunately, that is a myth, because I believe the most current quality metric systems tend to focus on diseases and or the plumbing of the office and not on the doctor-patient relationship, and therefore they're doomed to just not be as successful as we want them to be. Let me give you some examples. Pay for performance. I've been breaking these different examples down into a table that hopefully makes it a little bit easier to understand some of the potential benefits or drawbacks of the different things. But in pay for performance, the data input is done by the physician or employee. We're tracking diseases, and so the focus is on the disease. The number of determinants addressed, it's 1. You know, if you're looking at hemoglobin A1C, that's what you're looking at. Are there national baseline standards? Of course there are. Do better results equal better quality? And that's doubtful. And now why do I say is that doubtful? And I look at the Coleman et al. Article, which basically what they did was this was a community health center in, I believe, Wisconsin, where they tried to incentivize doctors to check the hemoglobin A1C more often. And what they found is, indeed, the number of patients with the hemoglobin A1C in the last 3 months did get better, or did go up, there's no question. However, the average hemoglobin A1C actually got worse. So it wasn't actually improving quality as much as it was just adding to expense, because we were just checking tests more frequently. And the other question on this is the doctor-patient relationship enhanced? And I say no, and the reason why I say it's not enhanced is because if you're getting paid to get people to goal, and the goal is a disease number, so hemoglobin A1C less than 7, let's say, then what do you do with the patients who are not able to get to goal? Do you kick them out of your practice? Do you just call them non-compliant? I mean, how do you work with them? What's the incentive to work with them? And so the answer is yeah, I mean, it's not, unfortunately, enhancing the relationship as much as we want it to. It's looking at the disease, not the patient. So let's look at the United Kingdom, because they've had an extensive experience with it. Pay for performance was instituted in 2004 there, with substantial payments for meeting each of 136 different indicators. Lots and lots of different indicators. What they found was that indeed, pay for performance accelerated improvements in quality for two of the 3 conditions in the short term. Unfortunately, once the targets were reached, improvements slowed to levels worse than before the incentive, and quality declined for the conditions not linked to the incentives, and continuity of care, which of course I described as one of the big, or that Starfield believes is one of the important components of effective primary care, actually decreased. So although there was some improvement in some of the conditions in the short term, generally speaking, it was not as wonderful as everybody had hoped. Let's look at the National Demonstration Project in the United States. The National Demonstration Project, 36 highly motivated practices were divided into 2 groups. They were actively managed and website assisted. $8 million was done. This was done through the American Academy of Family Physicians. These people that were picked to be in this study were really like they were like the first astronauts. I mean, it was really highly touted. We are going to help change these 36 practices into the practices of the future. Give us 2 years. We'll push every button we need to push in order to make these the practices of the future. So what happened after 2 years? Well, they came up with the result that change is hard. That indeed most people made some change, but the overall pace of change was very, very slow. And they also found that there was a lot of change fatigue. That people got tired of it and tended to go back to the way they were practicing before the National Demonstration Project started. There was no difference between the actively managed groups and website-assisted groups. So if you had somebody come from the outside and come to your practice and look over all the stuff and give you advice on how to improve it, or if they just went to a website, essentially the same, they got essentially the same results. And the only statistical difference from before and after 2 years was a decrease in overall patient satisfaction. So there was really no improvement, and unfortunately patient satisfaction went down. That does make some sense because these practices were not paid more to be in the National Demonstration Project. And so they actually had to work quite hard to change things around. And as processes change, there's disruption in patient flow. The thought is that maybe if the National Demonstration Project went on for 4, 5, 6 years, they could demonstrate some of the changes that they were looking for. But basically, the 2-year study was not nearly as helpful as they hoped it would be. What about achieving meaningful use? That's the latest and coolest thing. Meaningful use is an incentive program provided by the ERA stimulus funding, which allows up to $44,000 to providers who accept Medicare. It's basically electronic health record focused. You have to purchase and use an electronic health record which has been certified by the certifying body, and then you have to show that you meet certain criteria, which includes demographic criteria, smoking status, e-prescribing, vital signs, all these different things, these different components. So let's look at the meaningful use stuff. Well, the data input, of course, for meaningful use is going to be physician or employee. Basically, it's disease and process oriented. You could look at one or more different determinants. There are obviously baseline standards as to how to do some of this stuff. But do better results equal better quality? Just because you achieve meaningful use, does that mean you're actually providing better quality? That's unknown at this point. And is the doctor-patient relationship enhanced? I don't believe so, not initially. In fact, initially it might be diminished a bit, simply because, again, processes are being disrupted in order to try and improve things. The other thing is these electronic health record systems are expensive, and given how expensive they are, you have to see more patients per day in order to pay for them. And so it definitely is not, the relationship is not enhanced initially by adding one of these systems to your office. What about other things? NQF, HEDIS measures, NCQA, patient-centered medical home. All of these, again, I think are well-intended. I don't necessarily think that they will make a huge amount of difference. I'm not going to talk for very long on any of them. This is an interesting thing. There was an article published, or the Attorney General's report, actually from Massachusetts, Examination of Healthcare Cost Trends, 2011. What they found was that payment changes, absent substantive changes in care delivery, will ultimately fail. Well, that makes sense. You can't just give doctors more money and expect them to do better things. The logical route is to improve care through, well, there's a surprise, the different components of effective primary care. But there was an interesting part of the report which basically said that current measures of quality do not appear to address the failings of the current system. In other words, they couldn't, by looking at HEDIS measures, by looking at all these other things, they couldn't pick out which practices were, quote, good practices and which practices were bad practices. That basically the actual measures of quality themselves were not able to detect differences between practices. And that's important because, again, we're spending a lot of money trying to get this straight. Look back at the Starfield quote. And we say, it's not the one-by-one counting of diseases, their diagnosis, and their management that's important. That's what a lot of these quality programs are set up to do. And unfortunately, I think they're kind of doomed to fail because of that. So why does the current discussion matter? Well, because a lot of practices are trying to do the right thing, and it's a huge expense, and particularly to financially strapped practices. For many practices, adding an electronic health record system is going to push them over the edge. Also, it's confusion. Are we providing better quality? We're trying to. It's a distraction away from what's really important, and that's our relationship with our patients. Any distraction away from the doctor-patient relationship is lost time and lost revenue. It's not a good thing. And of course, the added stress removes the veil of autonomy, which decreases physician satisfaction. What I mean by that is we feel the pulse of others telling us how to improve. And so we no longer feel like we have that ability ourselves. So that finishes the first lecture. And I'm going to move to another YouTube video.